as mentioned, there are a number of large randomized adjuvant trials that help us guide our optimal management for patients with HER2 positive early stage disease. I think the one that's made the most impact in terms of changing our management plan is the KATHERINE trial, which, as I mentioned, is a study that looked at patients who received neoadjuvant HER2-directed therapy but had residual cancers. And in that study, switching patients from adjuvant trastuzumab to adjuvant T-DM1 had a large impact in reducing the risk of recurrence. So it's clear that the standard of care should be use of T-DM1 in those patients who have residual cancer after neoadjuvant therapy. However, the only way we're going to know who has residual cancer and thus who would benefit from T-DM1 is if they received neoadjuvant therapy. So based on the KATHERINE data, it is important to basically treat all patients with stage 2 or higher HER2-positive breast cancer with neoadjuvant therapy so that we can assess their responsiveness to that neoadjuvant therapy and decide who needs additional therapy with T-DM1. What type of neoadjuvant therapy you use is not that important. I think any of the currently standard approaches are reasonable. In the United States, I think a non-anthracycline regimen such as docetaxel, carboplatin, trastuzumab, and pertuzumab, or TCHP, is appropriate, or an anthracycline regimen such as adriamycin, Cytoxan, paclitaxel, trastuzumab, and pertuzumab, or ACTHP. Both of those regimens have been associated with very good pathological complete response rates in HER2-positive disease. I think there are some pros and cons to either one, but either are appropriate. And in those patients who have residual disease after receiving those therapies, T-DM1 is recommended. And interestingly, in the KATHERINE trial, the benefits of T-DM1 were also seen across the spectrum in terms of the amount of residual disease. Even patients with small, less than 1 centimeter cancers at time of surgery that were node negative still had substantial benefit from T-DM1. So starting with any neoadjuvant therapy, any patient with significant invasive residual disease should then receive T-DM1. Those patients who have a pathologic complete response from their neoadjuvant therapy can just continue with antibodies, either trastuzumab, pertuzumab, or just trastuzumab. We do not have randomized data in that regard. I think based on the APHINITY study, which, as I mentioned, for high-risk patients did show a substantial benefit to the inclusion of pertuzumab. That study did use the pertuzumab for 1 year, so in my practice, I continue pertuzumab along with trastuzumab in the patients who have a pathologic complete response if they started with reasonably high-risk cancer. So that's the recommendation for patients who have stage 2 or higher HER2-positive cancers, that they be treated with neoadjuvant therapy and that the results of that therapy be used to decide whether patients should continue with just trastuzumab and pertuzumab if they have a PCR, or switching to T-DM1 to complete the year of therapy. For particularly high-risk patients, one could consider the use of neratinib after the completion of their first year of adjuvant therapy. That is with the caveat that in the neratinib study, patients did not receive either pertuzumab or T-DM1 in their first year of treatment. So we do not know with any degree of certainty whether the use of neratinib in the second year of treatment has efficacy in patients who've received T-DM1 or pertuzumab. That being said, I think it's not an unreasonable extrapolation for particularly high-risk patients, and what I mean by that is patients with multiple nodes positive after neoadjuvant therapy who have estrogen receptor positive disease, because you remember that's where the benefit of neratinib is. It's worth considering using neratinib in that population, but I do think it's worth cautioning patients that we do not have definitive data specifically in that situation. Now, that's the recommendations for high-risk patients. What about low-risk patients? So here we have an interesting trial for patients who had low-risk disease. This was called the Apt Trial, and it defined low-risk cancers as those cancers that were either stage 1, meaning a T1 cancer 2 centimeters or less that's node negative, or it also included patients up to 3 centimeters that were node negative, but there was only a relatively small percentage of cancers like that in this population. So I think mainly we would view this as a regimen for stage 1 cancers. In that trial, which was a single-arm study, those patients with largely stage 1 cancers received just 12 weeks of weekly paclitaxel with a year of trastuzumab, with the trastuzumab started at the same time as the paclitaxel. That trial, which enrolled slightly more than 400 patients, showed excellent outcome with a 3-year disease-free survival of approximately 97%. So there were very few recurrences in that trial when patients with early-stage disease were treated with the TH regimen. That regimen in general is fairly well tolerated. There is some alopecia, but most patients found the regimen quite tolerable. Certainly better than one would expect with multi-agent chemotherapy and trastuzumab. So for stage 1 HER2-positive cancers, the TH regimen is associated with good outcome and good tolerability, and I think it's the standard of care for these patients. There is really no reason to treat cancers that are felt to be stage 1 with neoadjuvant therapy because we already know that those patients do very well with just TH, so there's no reason to think about adding TDM1 for such patients.